Hi, welcome everyone. I am Jenny Starr and I'm the Health and Wellness Specialist for the Kansas City Public Library. And we're so excited today to present in partnership with the Center for Practical Bioethics to have the Caring Conversations program today. Our expert program deliverer will be Polo Camacho. And we will turn most of the time over to him, but just a few little kind of housekeeping things. If you have questions, you can always add them to the chat. We'll monitor that. And also, we don't have so many people that it would be difficult to unmute and ask questions. So if you feel like doing that, you're welcome to do that as well. Polo is going to talk more about the Center for Practical Bioethics, but I just would like to mention that they have been a wonderful partner with the Kansas City Public Library for many, many years. And we so appreciate the work that they do. They're right here in Kansas City, even though they are national experts on bioethics. And we are really fortunate. They are just a few blocks away from our central location in downtown Kansas City. So with that, I'm going to turn the time over to you, Polo, and we'll keep an eye on the waiting room in the chat. Oh, Polo, I accidentally muted everyone and I muted you too. Sorry.
Are we good to go? Wonderful. Well, I just want to take this time and thank Jenny and Karen, who have been so wonderful working with us here at the Center for Practical Bioethics on these presentations. Really, it wouldn't be possible without them. So I just want to give them specifically a shout out. So let's go ahead and get started. Welcome, everyone, to Caring Conversations. My name is Dr. Polo Camacho, and as Jenny and Karen mentioned, we are just right across the way from each other. I'm just happy to be here and happy to be giving this presentation to you all. So you all might be wondering, what is the Center for Practical Bioethics? Who are we? What are we doing? We're a national leader in bioethics founded in 1984 by a lawyer, a physician, and a philosopher. We're a freestanding organization, which means that we have no ties to big pharma. We have no ties to any particular healthcare system. We are completely freestanding. We're not for profit, which means that all of the resources, all of the money that's sent to the center goes into programming like the programming like what you're watching here today, this Caring Conversations workshop. We offer bioethics educational resources for the public. And what sets us apart from other bioethics centers is that we work directly with hospital ethics committees. We work directly with healthcare providers on improving their practice from a bioethical perspective. And we also work with community members. We work with individuals like you all who are watching this today who are curious about health navigation and end of life things. And one thing that we like to say at the center is that we provide guidance at the crossroad of decision. This will become clear as we delve further and further into the presentation, but what you should know is that when you're in a sticky situation related to end of life, healthcare navigation, that's what the center is here for. We're here to help you out. We've addressed questions related to, durable power of attorney for medical decisions. We've addressed questions related to, hospice care, palliative care, everything from, administrative questions related to end of life, all the way down to, my mother's in the hospital and she really needs help. And we're not sure who to talk to. We're not sure what her options are. And we are bewildered by this entire process. So we offer guidance on all sorts of things. Today's presentation, though, is going to be on advanced care planning. What is advanced care planning specifically? Well, it's what our Caring Conversations programming is about. We help individuals like those of you watching today make explicit what your healthcare preferences are. We help you document those preferences. So if something were to happen, if you were to lose consciousness or lose decision-making capacity, you would have all the resources set in stone to ensure that your preferences and that your rights are upheld and promoted within the healthcare system. Um, that's kind of a lot. And we're going to break all of this down as the presentation continues. And hopefully by the end of this presentation, advanced care planning goes from being this technical jargony term to being something that you all can relate to, and to becoming something that maybe you all would want to do for yourselves. So really quickly, Caring Conversations, what does the center do in relation to advanced care planning? We provide coaching. We provide assistance to people navigating advanced care planning. We're your advocate. So if you're confused, bewildered by any step in this process, whether it's how do I talk to my mom about advanced care planning? How do I talk to my community about my own wishes and what I would want if ever I were to lose capacity? We step in and we provide advocacy support for you. We help you navigate what information is relevant. In many cases, when you're navigating through these really complex issues, it's hard to see what exactly is relevant and what exactly isn't relevant. So, what we do is we step in and we help you identify factors that are relevant for your decision making in these times of crisis. And then finally, we provide educational programming related to advanced care planning. So, we give presentations, we offer workbooks and various resources to help you get started. And really, at bottom, if there's anything you take away from this presentation, anything at all, it's that advanced care planning and caring conversations, this entire program, as you're watching it, it's about having a conversation. That's really the foundation, the bottom of the pyramid, if you will, to advanced care planning. That's really what sets our organization apart when we're talking about advanced care planning, and really what we count is absolutely fundamental to this entire process. So why have conversations about end of life? Why have conversations about, what is going to happen to me if I lose decisional capacity, if I lose consciousness? Why should we talk about this? Well, having the conversation about your medical care with family and friends can mean the difference between a family that's torn asunder, that's torn apart by disagreements over what mom would have wanted, and B, the peaceful, dignified end that we all want for ourselves and for those we love. We've all seen this before, whether it's through secondhand experience, direct experience with a relative. When things happen, when emergent scenarios happen, and a loved one is in the hospital or in the ICU, a lot of confusion comes out, and it's difficult to make decisions when there's so much disagreement. What advanced care planning does is it ensures that everyone is on the same page via conversations about end of life. Um, so you might be wondering, as you all are watching this, if advanced care planning makes such a big difference, then why aren't more people having conversations about this? Well, an answer to this question, some of these answers are relatively straightforward. We're generally reluctant to talk about end of life, right? Like we don't want to be a wet blanket and bring up end of life issues during a family gathering to coworkers and friends. Um, we don't like to talk about it, much less plan for it, right? We often like to walk the path of least resistance. We generally like having conversations that make us feel good. We find that talking about serious illness might be perceived as impolite or uncomfortable. So we generally avoid these conversations. And this is related to the first point. We walk the path of least resistance. We like to have nice conversations, polite conversations about things that we generally don't like to talk about end of life. And also, finally, and this is what we're going to be talking about, the bulk of what we're going to be talking about during this presentation, is that many of us hold mistaken beliefs about advanced care planning. And we're going to delve into those mistaken beliefs here uh, uh, right now. So, mistaken belief number one, you might be watching this and thinking to yourself, I don't have to plan because I will always be in a position to make my own healthcare choices, right? And so you might be thinking to yourself, not only is it impolite to have these conversations with families and friends, but also why should we have it, right? Many of us are going to be okay when that time comes. If we're diagnosed with cancer, some serious disease, some advanced disease, we might take it that, well, when that time comes, we'll be able to have conversations with loved ones. We'll be able to have conversations with our medical team, social workers, etc. The issue with this belief is that it's not true. First of all, there's no empirical basis that we'll be in a position to make our own healthcare decisions when emergencies happen. 85% of us will die without the capacity to make our own healthcare choices. Now, think about that for a second. Many of us have this ideal notion of what our death is going to look like. Perhaps for some of you watching today, you're thinking, when I die, it's going to be this peaceful, end. I'm going to be diagnosed with an illness at a very old age, and I will slowly fade and pass away with loved ones surrounding me, and I'll be able to make my own choices. 85% of us will not have that. What's more, practical constraints. Constraints that occur within hospital settings will make it difficult for us to communicate our decisions. Now, the picture in the middle that you're seeing is an image of a hospital shift change. This is when nurses, doctors are replaced by other nurses and doctors in a particular hospital setting. Ask yourself really quickly, if I'm in a position to make my own healthcare decisions and my information is jotted down in chart notes, what's going to ensure that my preferences are going to be communicated with accuracy during a hospital shift change, right? Your preferences could get lost, reinterpreted during this change, whether you're in a hospital, in an ICU, or some long term care facility, right? Then finally, how we die is changing. There are illnesses that happen that make it really, really complicated and sometimes not possible to communicate our healthcare preferences, like Alzheimer's, dementia. And so the belief that we will all be in a position to make our own healthcare decisions, the idea that that is guaranteed, is not backed empirically, right? Um, and really quick, we might be thinking, well, I have my legal stuff squared away, I have my DPOA form squared away, that is going to be enough. Again, forms like the DPOA for medical, though helpful, is not going to inherently guide action, right? Your appointed healthcare agent might not even know what you want. So you might think, well, even if I'm not in a position to make my own healthcare choices, years ago I appointed Sarah as my DPOA. She'll know what to do, without having conversations about exactly what you want. Everything from your social desires to your religious desires, all the way down to the clinical. Appointing someone in and of itself isn't going to ensure that your preferences are honored in times of crisis. There's a difference between the life we say we want, as I noted earlier, versus the life that we get. Many of us, again, have this image in our minds of what our lives are going to look like down the road. But this is going to rub up against facts, right? What do we want? We want pain free care. We want to be in our own bed. We want our symptoms to be palliated and managed versus being hooked up to machines. Many of us say this, right? When we're talking to family and friends, when we muster up the courage to talk about end of life, we say things like, we don't want to be hooked up to machines. Generally speaking, most of us want to be comfortable during these end of life moments. What's more, we want our preferences to be honored and we want them to be recognized by staff and our friends versus, as we noted earlier, disputes happening in the waiting room, disagreements, arguments over what we or our loved ones might want. And then finally, what we want is our psychosocial needs to be met versus being alone, being isolated. Those working in geriatric settings and palliative care settings and hospice care settings that are working with those that are aging and the elderly will often note that in these moments, one of the top things that is on the minds of those who are elderly and aging is being alone. Many of us don't want that at the end of our lives, right? What we want is for family to be surrounded by family and friends, not to be isolated from the rest of the world and our families. Now, here, kind of going back to what I was pointing at earlier, many of us have these trajectories, these ideas of what our deaths are going to look like, right? Um, I want you all to look at these four pictures of illness. These are all illness trajectories. Illness trajectory number one, this is my friend Gabe. My friend Gabe, we went to high school together. He taught me how to play guitar and was an incredible person. I remember the first song he ever showed me. For those of you watching and that know this song, he taught me Everlong on guitar by the Foo Fighters, and I was eternally grateful for that. That turned into a deeper interest in music, and I credit him as being the person responsible for having me, gone into music. In my earlier years, I was in bands, I played all over our city, and to this day, he's credited as the person that taught me all of these things. Imagine my surprise when years later, after I played music in various bands in my hometown of El Paso, Texas, and am in Kansas for graduate school, I receive a call from my friend who says, Polo, you'll never guess what happened to Gabe. I didn't know what was going on with Gabe. We had lost contact after a really long time. He wasn't really on social media, so it was hard to keep track of what was going on. But my friend tells me Gabe passed away. And I, dumbfounded and surprised, it turns out that he had passed away in the shower from a heart attack. Gabe was 30 years old, and this is a sudden death. It happened unexpectedly. That encapsulates illness trajectory number one: sudden death, an unexpected cause. Illness trajectory number two also complicates this ideal notion in our minds of what our death is going to look like: a steady decline, a short terminal phase, an advanced cancer diagnosis. And this is my aunt Erlinda. Erlinda was diagnosed with advanced cancer. She wanted hospice care, and slowly over time, she was losing organ function, and she was slowly but surely losing decisional capacity. That was her trajectory. She ultimately ended up passing away in her home in hospice care, um, next to her garden. Illness trajectory number three: this is a slow, steady decline, a periodic crisis that ultimately leads to death. This is progressive heart and lung disease. This is my wife's grandfather. My wife's grandfather, his name was Fernando Diaz Ball. He was an amazing person who suffered from lung disease. He had really bad asthma, had various inhalers, and there were moments where he had emergent crises happening, and so we would have to take him to the doctor. He'd have to go to the doctor for asthma attacks and such. And that trajectory number three, it and wound up passing away from a lung disease at at an old age. And so this is another trajectory that many of us don't think about. Some of us have these chronic diseases, whether it's heart disease or lung disease, that complicates this ideal notion of what our deaths are going to look like. And then finally, illness trajectory number four encapsulates a lingering expected death. And so all of these different pictures, I hope that in seeing each of these trajectories, you can see a little bit about you. It begins to get clearer what illness trajectories are out there, what they look like. In fact, you might be familiar with some of these. So each of these trajectories will complicate the idea that we'll be in a position to make our own healthcare decisions, and also that there's this ideal that we're going to achieve this ideal for what our death is going to look like. There's a difference between, again, the life we say we want versus we get. This image at the very top left-hand corner of your screen is an image from one of our former board members, and we use this image with her permission. She encouraged us to use this image. She was a big proponent of advanced care planning, and when she was diagnosed with a terminal illness, she expressed, "What I want is to be next to my family, in my bed, comfortable with my dog, and next to my daughter. I want to be surrounded by family and in-home care." That's exactly what she got, and that's exactly the image that you're looking at up here in your left-hand corner. We want to be surrounded by loved ones, right? And here you see her comfortably laying next to her dog with her favorite blanket and next to her daughter. That's what we want. And at this point, what I want to say is that though for many of us, this ideal notion of what our death is going to look like and what the end of our lives is going to look like, though for many of us, that's going to be complicated by the different illness trajectories that we saw, the various facts about end of life. Through advanced care planning, we can achieve an ideal that's closer to this versus what? The image that we see at the bottom. Intubated in the ICU, again, hooked up to machines, on life support, in isolation, without family and friends. COVID 19 has further complicated advanced care planning and has further complicated honoring end of life preferences. It's never been more important than right now to have conversations about end of life. Again, that should be the theme, right? Is that we need to have conversations about the end of our lives, what we want, and who we want to speak on our behalf when things happen. For many of us watching, we might be thinking, well, the vaccine is out, everything is okay. I assure you, it is not okay. The virus is no respecter of persons. Any one of us can get it, and people are still dying from COVID-19. How, in moments of crisis, would we be able to make our healthcare wishes known when on a ventilator and on life support? People in nursing homes, for those of you watching who are familiar with nursing, hospice nursing, long-term care nursing, palliative care nursing, what have you, people in nursing, you all know that it is really difficult, especially early on in the pandemic, for families to even convene with their family members, right? For patients to convene with their family, and this makes it even more difficult to communicate healthcare, which is why, again, the conversation is so crucial and it's so important. Mistaken belief number two: My family already knows what I want in terms of healthcare. You might be thinking, Polo, not only will I be in a position to make my own healthcare decisions, but my family generally knows what I want for myself. We've had a chat about it. Now, I really want to ask you all, and this is, these are rhetorical questions, obviously. When was your last conversation with a loved one? Who did you talk to? What did you talk about? In many cases, being telling a family member that you don't want to be hooked up to machine needs a little bit more nuance. You need to unpack that a little bit. So, though it may be the case that you spoke to a family member or friend about what you want at the end of life, perhaps it's worth going into a little bit more detail. And what's more, perhaps it's important to talk to someone who you may think could honor your preferences in that uh, moment, that time of crisis. The truth is, having conversations, these conversations in particular, is really difficult. Many of us haven't had them. Some family and friends, as willing as we are to have these conversations, they themselves might be unready and unwilling to have these conversations. That's a hard truth. And then also, some family and friends may not be absolutely certain about our healthcare wishes. What I tell people sometimes is that your healthcare wishes go beyond the clinical. They go beyond wanting or not wanting to be hooked up to a vent. They go beyond wanting or not wanting to be hooked up to artificial nutrition, hydration, or mechanisms for artificial nutrition and hydration. Sometimes what we want is to be surrounded by family. Sometimes what we want is to be reconnected with a loved one that we haven't seen in many, many, many years. Sometimes what we want is music playing in the background, right? Um, so it goes beyond the clinical. Also, we can't assume that anybody has a precise grasp of what our healthcare wishes are. Sometimes we have to go beyond the conventional sort of we don't want to be hooked up to machines, and we need to be explicit. Do we want to, in the case of my aunt Erlinda, she didn't want to go to a hospice facility. She wanted to be home. She wanted to be cared for by a medical team at her home. And that's exactly what she got, right? So those particularities can come out during the conversation with loved ones. Um, and then there are consequences that come from having the mistaken belief. And here, my colleague Linda Ward, who is a former executive at the Center for Practical Bioethics, tells this really, really interesting story. It's called "A Call from the Waiting Room." Now, in her, working in end of life, many of us at the center have received phone calls from folks navigating, healthcare situations, healthcare crises. This is a particular call that she took from an ICU from a major hospital in Kansas City. She receives this phone call, and she hears that on the other line, people are bickering, people are arguing. And she notes that during the phone call, this woman is speaking to her and says, "Listen, I'm in the hospital waiting room. I'm with all of my siblings. I've been appointed a DPOA, co appointed a DPOA, a decision maker for my mom in conjunction with my brother, but my brother and I are disagreeing about what my mom wants." Linda goes, wait a minute, wait a minute. So, okay, let's back up a little bit. So what exactly is going on? This woman says, "Well, we want to know who is going to make decisions for my mom. Should I make decisions for my mom? Should my brother make decisions for my mom? We're trying to figure out her care right now." Linda then pauses for a moment, noting that in many questions and in our experience, the question that you get over the phone is not always the question. So she asks a little bit more about her mom. She goes, "Tell me about your mom. What's going on?" She explains her medical history and says, this is why she's in the hospital right now. And we're currently trying to, coordinate her care and achieve the best care possible for her. And then Linda asks further questions. She goes, does your mom have decision making capacity? Is she conscious? The daughter goes, "Absolutely. Yeah, she's right here. You can talk to her if you want." Linda then goes, "Well, wait a minute. Um, no one can make decisions for your mom because she can make them for herself. She's completely conscious and she hasn't lost decision making capacity." So she ends up talking to the woman and says, "You are in a position to make your own healthcare decisions. You have not lost decision making capacity. You sound cogent, and it appears your medical team agrees with this. So the bickering that's happening in the waiting room is completely moot." Right. So these are the kinds of phone calls we receive at the center. And these are some of the sort of the truths that reveal themselves to us as we're navigating end of life. Mistaken belief number 3. Polo, I don't have my healthcare wishes. Not only do I not have to talk about them, I don't have to have my family on the same page. My doctor will know what to do in that moment. I have a primary care physician who is more than capable to make decisions on my behalf. So sorry, not going to have it. What's wrong with that? We'll go back to this slide really quick. What's wrong with this belief is there's a reason why the Center for Practical Bioethics exists. Without going into too much history, the center's history or the center's role in society and in relation to other healthcare systems in the community is to really drive forward this idea that doctors, physicians, though they're incredibly proficient in doing their work as medical professionals, may not always have a sense of what your preferences and values are. That's where we come in, right? So a doctor, a physician may know, well, given this state, given this prognosis, these are the set of medical treatments that would be beneficial to you. Really, at the end of the day, what needs to be communicated to your doctor is what your values and your goals are. And that's what this entire program is about, right? Your doctor may know what's right in terms of treatment, but they may not know what your values are. They may not know what your goals are. They may not know that you want to be reconnected with family members at the end of your life. They may not know that you prefer in home hospice care versus hospice care in a facility. So that I hope that you all can sort of see that we are in a position, those of you watching here today are in a position to promote your own wishes and your own preferences. Some of you all might be thinking, well, if I document anything, that should be enough. My medical provider will have everything documented on a sheet of paper. That should be good. Again, the legalistic approach sometimes fails to capture nuance. The living will alone won't ensure that your goals of care will be met. So you might be thinking, if I document everything I want onto a sheet of paper, this alone will serve as a baseline or as a springboard for my doctor to make decisions for me. Really, though, really having conversations, supplementing that documentation, supplementing the living will go a long way. um Crisis are absolutely crucial. Now I'm going to go back to an example to illustrate the significance of the conversation yet again. My wife's grandfather, who I noted earlier, his name was Fernando Diaz Ball, um, uh, from Puerto Rico, served in the military here in the United States and was stationed in along the border of El Paso and Juarez. Um, as much as we tried, Fernando Nani didn't want to have conversations about his care. Every time we brought it up, this is throughout the years and years and years that I had been with my wife, and even before that, was generally evasive, generally unwilling to have these conversations. Nani was an incredible person. He introduced me to Puerto Rican food. My wife is Puerto Rican, introduced me to salsa. We had such amazing times. But whenever it came down to planning for these sorts of things, he wasn't unwilling to do it. He wasn't willing to have them. So my wife and I end up, as I pointed out earlier, moving to Kansas for graduate school. And while in graduate school, I receive a phone call from a family member noting that he's not doing very well. And so we immediately fly back home, and we see that he's completely lost decision making capacity. We had no idea what was going on. We were told that he was doing okay, that he was doing well, but it was incredibly frustrating not being able to make any advances in his care that we know he would have wanted, all simply because we never had conversations about his care. He had written some things down here and there, but really nothing was codified. No one was on the same page. Everyone was in disagreement. And so this is an incredibly painful time because we're in front of this individual who effectively took me in as his grandson, his adopted grandson, and we couldn't do anything for him. And so I hope that this anchors the importance of supplementing any documentation, any legalistic form with a conversation. Mistaken belief number 4, I've written it down somewhere, so I don't necessarily have it, right? Again, going back to the point that I mentioned earlier, writing things down in and of itself won't ensure that your healthcare preferences are met. Conversations are absolutely crucial. And if you have written it down, we should ask, where is it? Somewhere where family, friends know where to find it? Will this documentation be enough? If you scribbled it down on a napkin, where's the napkin? Do loved ones, if they do find the napkin or if they do find the document that you've written something on, do they have a clear understanding of how to execute your wishes, even if they do have access to it? So here's more evidence supporting the efficacy of the conversation. These are all citations. I'm not going to go into them for the sake of time, and because I really want to talk with you all and get a sense for how the center can help you all through advanced care planning. But this is all evidence supporting the efficacy of the conversation, supporting the idea that early conversations about patient goals of care and priority for those living with serious illness that are absolutely important and crucial. It reduces suffering, it improves patient satisfaction, improves quality of life, and it decreases non-beneficial care. Too little, too late, not great. This is all evidence supporting the idea that when we do have these conversations, it's oftentimes too late or nearing the moment of death. And so, again, what we really want to encourage you all to do today is to have these conversations early on. Don't just have them once, have them repeatedly once a year, just like taxes. And we'll touch on that here in a moment. So, as a recap, not all of us will be in a position to make our own healthcare choices. Our families and friends don't necessarily know what we want. Doctors don't always know what to do. Again, they're experts, they're proficient in diagnosing and prescribing, but perhaps they don't have a sense of what you value and what you care about. And even if you've written down your preferences, this alone is simply not enough for them to be honored in times of emergency. Again, the conversation about end of life is at the bottom of the pyramid. Everything else is at the top. The documentation, the DPOA, the legalistic frameworks, everything. So what do we do now? You might be watching this and you're like, okay, Polo, I get it. Advanced care planning is important. Having conversations about end of life is important. How do I get started? What should I do? Luckily, the center has a variety of resources to help you get started with the conversation. And I want to point out here that we're not the only game in town. There are a lot of other advanced care planning programs that you could benefit from. Really, what we want to emphasize is not so much the artifacts, the resources that we provide, the workbooks, but really what we hope lands for you all is the efficacy of the conversation. Having said that, though, I will dive into some of the resources we have at the center. What you see in front of you is a work aid and a workbook. The work aid is what I like to call the icebreaker. Perhaps you're thinking to yourself, I'm not quite ready to have the conversation with family members yet, and I'm not even really sure how to approach them with anything yet. I'm not even sure that I want to fill out any documentation yet. What can I look at? Well, the center, apart from our website, which you can visit at www.practicalbioethics.org, we also have these work aids, which are icebreakers. These are just a way to delve into the nitty gritty, a way to delve into advanced care planning and end of life for those who are uninitiated and don't really know where to get started. For those of you that are watching and do want to get started, you do want to start reflecting preferences and also communicating those preferences, your values, what you want and what you care about to families and friends. There's also a workbook that will help you get started with the conversation. Workbook overview. I'm going to give a very, very brief overview of the workbook so that you can see how it works. And these are downloadable for free. Jenny Starr and Karen Whitestone, they have physical copies of this if you would like those. And you can also download this for free at the center's website at www.practicalbioethics.org. Step one in the workbook, reflect. Think about your values, your beliefs, your concerns. Some of us value education, for example. And so at the end of life, in addition to wanting to be kept comfortable, maybe some of us want to listen to a podcast, right? Maybe some of us want to watch a YouTube video, or maybe some of us want to listen to a tape or some kind of recording, an educational recording. This is all relevant to advanced care planning, right? Think about what's important to you. I love music, for example. Using myself as an example, I know that at the end of life, I will want music playing nonstop, have the radio going, have my favorite playlist going. That is what I would want, right? Again, this goes beyond the clinical. This goes beyond and though that's important, right? This goes beyond the clinical and also has implications for the medical. Ask yourself, as you're reflecting about your beliefs, your concerns, and your values, what does a good death look like? This may seem like a moron, right? What does a good death look like? That's weird, Polo. Well, no. The moments leading up to our death are incredibly significant. And we might, we have a sense of what we would like to achieve and what we would like, the reality that we would like to veer away from. Think about that. What does it mean to die well? Step two, talk. Communicate your wishes. Now that you've identified what you value and what you care about and what your preferences are, communicate these wishes, values, and concerns with loved ones. If you're severely ill, do you want to be surrounded by family at home? Do you want your pet next to you? Do you value comfort? Do you have a blanket that was handed to you, a quilt of some kind that you would want by your side, right? Communicate all of these things to your friends, people that you trust, right? Your close circle. For those of you watching today thinking, well, Polo, I don't really have family. I have a few friends. Talk to your friends about it. And for those of you that maybe don't have community, this could maybe serve as a starting point for thinking about community and what that means to you at the end of life. Step one, reflect. Step two, talk. And here are some tips for having the conversation. Use comfortable language and take your time, right? Check for understanding, discuss practical issues. Invite friends over to your house, invite them over for a drink, invite them for a coffee, go to your favorite dive and sit down and talk with them, or take family members to a restaurant. I've even heard of individuals who took family members on vacation solely so they could have these conversations. Share your psychosocial, spiritual, and religious concerns. And also remember, as you're having these conversations, that dying is a part of life. Step three, appoint. So you've reflected on what you value, you've talked to your community, your inner circle about what your preferences are. Now it's time to appoint someone to speak on your behalf when, if it were to happen that you can't speak yourself. This is what we call the healthcare representative, formally appointed as a durable power of attorney for healthcare decisions. This is going to be the individual that will have your back if you lose decision making capacity. As you're thinking about who to appoint and who to elect as your surrogate decision maker, your healthcare representative, whatever you want to call them, remember that not all family and friends are created equal. For those of us in families or in friend communities, we know who operates well in a crisis and we know who doesn't. That may be a good starting point for selecting your appointed agent. Select the person that is most able to speak on your behalf based on preliminary conversations, someone that you know is going to uphold what you want over everything else. Who should you appoint? We're not going to go over the right home exercise. We already told you who among your family and friends are composed. That is an excellent starting point for appointing a DPOA or a healthcare representative. And also inside of the workbook is a form to appoint someone legally as your DPOA. I could delve into specifics there at the end of this presentation for those of you that have questions. Step four, document, right? Act. Document your wishes, appoint your agent, fill out your workbook. And now that we've had the conversation, which I've noted is at the bottom of the pyramid that I call advanced care planning, make sure everyone knows where your workbook is, right? Some of us like to have it on the refrigerator. Some of us like to have it on top of the refrigerator, or you could put it in a filing cabinet. It doesn't matter where you put it. What matters is that everyone knows where you put it. And for those of you who may be more technologically inclined, there are ways to save your workbook digitally, and I'll dive into that here shortly. So, in summary, what the workbook generally goes over is it helps you reflect about your wishes and your preferences. It helps you talk with loved ones about your preferences, appoint someone as a decision maker, and then finally act, right? You're documenting all this in the workbook and you're making sure that everybody knows where it is. These are the four very simple steps. And again, whether or not you choose to go with caring conversations, really what we hope you take away from this presentation is that the conversation matters. So what have we been talking about this entire presentation? The advanced directive, right? I didn't want to introduce this language at the very beginning of the presentation because I personally don't believe in communicating jargon in every single setting that I'm in. So the DPOA form, as I noted, is inside of the workbook. The workbook, when filled out properly, constitutes an advanced directive. It constitutes a way of documenting your healthcare preferences in times of crisis, and also appointing a surrogate decision maker to make decisions on your behalf in the event that you can't make them for yourselves. So this entire process, this entire program about advanced care planning centers the advanced directive grounded in conversation. Who should have the conversation? Those 18 plus should identify, at the very least, identify a healthcare proxy agent. And here I'm going to tell a really quick story about my cousin, my second cousin, who passed away at a very young age in his early 20s. My youngest cousin, second cousin, was driving home with his girlfriend from church. Um, in the Camacho Rodriguez sort of household after church, it's tradition that we all go to dinner, that many of us go to dinner. And on this particular day, my family, on my maternal side, they all decided that after church they were going to go out to eat somewhere, maybe go to a relative's house and get some lunch. Um, my cousin, on his way home, was driving on a two-way street and was hit by a truck. Um, it was an incredibly stressful time for all of us, and none of us thought that this was going to happen again, further complicating this idea that we have this ideal notion of what our deaths are going to look like. This is unfortunately what happened with my second cousin. It was an incredibly stressful time. Anybody 18 plus should think about advanced care planning. Anybody 18 plus should at the very least think about, who should I appoint to make decisions on my behalf if I can't make them for myself in times of a crisis. Um, where should you store your workbook? Again, going back to the workbook, for those of you that are more technologically inclined, who say don't really want to save a physical workbook anywhere, you can fill out the Caring Conversations workbook online, and we can share a link with you here shortly on how to do that, and then upload this document onto mydirectives.com. Mydirectives.com is a free website. You can use it to upload any advanced care planning information. And the cool thing about my directives is, not only is it a way for you to store digitally your advanced care planning documentation, your Caring Conversations workbook, but it also allows you to send this information to your inner circle. So in moments of crisis, if something were to happen, God forbid, people could access, your community could access your advanced care planning at their fingertips by logging onto this website. And so my directives is this really, really cool mechanism. We work with them all the time, the folks at AdVault. And if you all are watching this and have any questions on how to do that, please reach out to us. We're more than happy to help you through that done process, right? If your planning is ongoing, we recommend that you have conversations regularly with family. Have conversations in moments where there are changes in family dynamic. Have these conversations when you are diagnosed with a new illness. Review your advanced care planning annually when you become severely ill, and especially as you're nearing the end of life. Each of these life events are signposts along the path of advanced care planning. We say two things. We say, have a saying here at the center, that death and taxes are, two absolute things that are definitely going to happen to you, right? So when you're thinking about, think about this as a process that's sort of a part of the tax process, right? We all fill our taxes every year. Well, maybe we should all be thinking about advanced care planning and renewing those documents once a year as well. And really baking that into one's life, making it a norm and destigmatizing end of life. So, your homework for today: complete your workbook, talk to those close to you, talk to your doctors. Physicians will receive a reimbursement for having conversations related to advanced care planning. And I can say a little bit more about that if you all would like me to. Share your workbook with family, doctors, friends, clergy, or attorney, whoever. Ensure that your community understands what your preferences are, right? And where they're documented and where they can access them. Store paper copies where they can be found. And as I pointed out, you can also upload them to mydirectives.com. So thank you so much. My name again is Dr. Polo Camacho. And you can, if you have any questions related to this presentation whatsoever, you can reach out to the Center for Practical Bioethics directly at 816-221-1100, or you can visit the center's website if you would like further resources on advanced care planning at www.practicalbioethics.org. And there's my information down here. My role at the center is going to change a little bit, but if any of you have any questions related to advanced care planning or Caring Conversations, please call this number. Um, I will be at the center working with them for an extended period of time. And so I just am really thankful. Thank you, Jenny. Thank you to the Kansas City Public Library for allowing me this opportunity. And yeah, I guess we'll open it up to questions. I'll hand it off to you, Jenny and Karen.
Sure. I realize I neglected to introduce Karen at the beginning of the presentation. Karen Whitestone is our health and wellness outreach specialist with the AmeriCorps Vista program and has done a lot to help coordinate this as well. If you have questions, feel free to write them in the chat, or if you'd like to unmute and ask, that's also a good thing to do. While you're thinking about that, I like to share that I recently had surgery and I had my documents that I got from the Caring Conversations booklet and brought them to put on file at the hospital. And they were shocked that I had that document. They got it so infrequently. And so I thought that was interesting. There's a big need for us to work on this in our country. So
Absolutely. That's awesome, Jenny.
Yeah, big round of applause digital round of applause for Dr. Polo Camacho.
yes.
And thank you for the intro. Speaking of the chat, I put a few links in the chat already, and I will continue to put some stuff in there, including a feedback survey. If y'all like this program or like this program through the library, like Polo, anything you want to say, we would love to hear that. And I will also keep the room open for as long as anyone needs. If you need to copy down the links after, you have a question, but you also want to get the links, don't worry, I'll keep the room open. And also there's a way to save the chat. And if you want to know how to do that, and you can message me directly, but it's right at the bottom of the chat box. So I'll go on mute and
Yes.
I'm really looking forward to everyone's questions.
Someone has asked, how do I save the chat info? And I feel like your trick is helpful if you would like to share it.
Okay, it's real quick. If you open up the meeting chat at the bottom where you typically type the message, or it says type message here, there's also the little send button, the little paper airplane arrow. And right on that same level as the send button, there's a ... symbol, an ellipses. And if you click on that, there should be a menu option that shows up that says save chat. I don't know if it'll save as a text file that then you'll have to put into like a Microsoft Word document or something like that. But it's a handy little tool. I love to share about it. I've definitely been saved, having 20 links pop up and be like, oh my God, what do I do? That's how you save the chat. Thanks for asking.
Yeah, I didn't know that trick until very recently. So, hey, any questions before we wrap up?
And if some of you all would rather ask a question directly, verbally, you're welcome to do that as well. Yeah, we can address any questions y'all might have.
Yes, someone just placed one in the chat. It says, is the information in the workbook required to be notarized?
It depends on the state that you're in. So I believe it's on the Missouri side that requires a notary. The DPOA for medical, the medical DPOA form requires a notary, but not on the Kansas side. What we generally recommend for those living in the metro on both the Kansas and the Missouri side is that you get it notarized anyway for transportability reasons. Living so close, I'm in Lawrence, for example, just 20-30 minutes away from Kansas City, and I work in Kansas City. If something were to happen, I would want all my ducks to be in a row, right? So we generally recommend that you notarize these documents. Jenny, is there a notary at the Kansas City Public Library?
I was going to say, incidentally, we offer notary services at the library, so you can find information about that on our website. Most of our branches have at least one notary on staff, but they're not always to call ahead, or you can make an appointment.
Perfect. Wonderful. So there you go. We definitely recommend that the DPOA form be notarized. As far as your everything that's written down about your preferences, that doesn't necessarily have to be notarized. It's as long as you sign it and date it, that information is okay. But we do recommend that the DPOA form be notarized for transportability reasons.
Yeah, that was a great question. Stephen has a hand up. If you'd like to go ahead and unmute, Stephen, and ask your question.
Thank you very much. This is helpful information in the workbook and in the presentation here. Uh, I, I had a conversation a few months ago with an individual who was describing some decision making that they had been making within their family about certain, uh, complications, medical complications like C. diff, or an elderly mother who might have UTIs or sepsis as sort of complicating medical conditions. And he was sharing that their family had this kind of a conversation about, well, would we keep her in the hospital, keep mom in the hospital, or do we bring her home? So my question is what's the best way for me to get more information about those kinds of, I think, infrequent or not infrequent complications that somebody can have once in the hospital? So that our family, we might talk about the practical aspects of that. So do you have any recommendation of where I can get more information?
Absolutely. So really the answer to this question, which as I pointed out, many times you have questions nested within larger questions. We offer end of life and health navigation services to the community. So if ever you or someone you know is in a situation like this, where maybe a loved one is being cared for in a long-term care facility, nursing home, independent living, what have you, hospice care, the center is generally a wonderful resource to reach out to when you have these sorts of questions. We can sort of address the particularities of the situation, settle issues on whether or not the patient, in this case, has decision-making capacity and can communicate their preferences. That all is going to be relevant in offering any, advice or any feedback on the situation. But Steve, I do want to let you know that the center, this is why we're here, and this is why we help people. We help healthcare providers navigate these sorts of situations. We help individuals navigate these sorts of situations. So feel free to reach out to the center. In fact, I'd love to chat with you after this presentation to maybe get a sense of what's going on and help maybe develop a concrete plan for how to move forward. But the center is generally a wonderful resource for this sort of thing. And what I like to say is that if we don't have the answer, we know someone who does, right? We're part of a wide network of folks who promote end of life, goal concordant care, and we can likely connect you with someone. Sometimes, for example, we receive calls about estate planning. We don't do that, but we can help with these sorts of situations where there are questions about, we deem a particular setting or a care plan to be beneficial. How can we move that forward given the situation? So feel free to reach out to us here, Steve, at the main number up at the top, or you can call me and we would be happy to help you through that.
Okay, well, I appreciate that very much. Thank you.
Absolutely. And spread the word about what we do too. Let other people know that.
Okay, will do.
Awesome. Thank you, Steve.
Thanks. We have another question in the chat. Isn't there a form to have our medical information be transferable? That's easy for me to say. Transferable between states. I can't remember the name.
I don't know about that specifically, but I do know of an initiative called the National Post. And generally what the National Post organization promotes is a physician's orders for life-sustaining treatment. And so that's a part of advanced care planning. What they're promoting ultimately is a part of advanced care planning. And what they're hoping to do is to make information like what we talked about here today transportable across all care settings. I don't know if that's between states necessarily, because different the National Post, I think, has different locations or is endorsed in different states, and each state has its own version of that. But yeah, I haven't heard of that. The sort of the crossing state line. I suppose if all the information is documented accurately and it's uploaded to something like mydirectives.com, there would be a way for, especially now currently, there's a way to add your primary care physician and your medical team to that. So if your medical provider is in a different state and they have access to that information, they would be able to retrieve that information easily in times of crisis. But yeah, I'm not sure of anything outside of those two things that would allow that. But if you know, feel free to follow up. I'd love to learn more about that.
Okay. Well, I think we are at the end of our time. We don't have any more questions in the chat, and I don't see any hands up. So I think we're safe to conclude the program for today. But Polo, thank you so very much. Thanks to you and to the Center for Practical Bioethics for presenting this for us today, and for all the work that you do, and just being a resource for our community and beyond that.
Well, thank you all so much. It's been an absolute pleasure. So, so thankful to have worked with you all, and I'll see you all later. Thank you so much.
Thank you.